Let's see. Excellent. Okay, good morning, everyone. It's great to see you. Thank you for sitting patiently with me for a few minutes. We may have some more people rolling in here as well. So, but we are going to go ahead and get started. We've got a pretty busy agenda today. This meeting is being recorded, and we will be posting the recording at the Get Healthy NoCo partner page. We'll send that link out to everyone in case you didn't bookmark it the first couple of times that you got it. Even though we're recording, keep in mind that as we go into, we're going to do some quick little breakout sessions here. The breakout sessions are not recorded, so don't feel at all inhibited, by that. So with that, I'm going to go ahead and get us going. So welcome and warm up. What we're going to do is a couple of rounds of what we're calling a rapid fire mix and mingle. And so the intention here is just to get everybody, to start meeting each other and having some conversations. This is really intended to be fun. It's early in the morning, so hopefully get everybody woken up a little bit so that before we get into the agenda. So what we're going to do is we're going to be randomly assigning you in pairs to breakout rooms. And each pair or team is going to be given a couple of minutes to share some piece of information with each other. And at the end of the 2-minute round, you're all going to be returning to the main room, this room, and then you're going to be broken up again randomly into another pair and put into another breakout room and given an assignment for that. So this process, like I say, will be repeated 2 times. So that by the time you come back to the main room the second time, you will have connected with at least 2 other people who are participating in this meeting. So we will put the questions that you're going to be discussing into the chat when you get into your breakout room. So if you can't remember what we say next, don't worry about it. You'll see it in your breakout room. So everybody ready to go for a little trip? All right. So round 1. We're going to ask that everyone take 60 seconds to introduce yourself, where you work, where you went to high school, and what you did for extracurricular activities. All right, so that's the assignment. Introduce yourself, tell your partner where you work, where you went to high school, and what you did for extracurriculars. And with that,
go ahead and open all the rooms now.
Great. Thank you, Dan.
Yep.
So how's it looking?
I think we're good. I think everyone has 2.
Everyone's in.
Good.
Yep.
Okay. Awesome. Good job.
You got your timer going?
Sure do.
Cool. You've probably told me this, but where did you go to high school, Ann?
It was called Indian Hill High School in Cincinnati, Ohio.
Oh.
Mm-hmm. And I was an athletic trainer. I was a student athletic trainer. I was going to go to, my plan was to be an athletic trainer. It's a long story.
That's cool.
Yeah. And I know both of you went to Saranac Lake. What were you, and you were hockey. What did you do, Dan? We shouldn't be interrupting him.
I know, Dan, you focus on your timer.
Okay. I did football and lacrosse.
Oh, okay.
Dan actually played football with my brother.
Yep. He was our quarterback.
Mm-hmm.
So that's why when I told John Muldowney that you were working for us now, he was very excited to hear that.
That's
yeah.
good.
Ron's having fun.
Mm-hmm.
Oh, someone's coming in.
Yeah, we'll just keep her here. I think we're at the end of our round, right?
Just about, yeah.
Hi, Samantha. We're in a little breakout right now, but you got here just in time to join the second breakout.
Okay, thanks.
All right. I'm gonna go ahead and close the rooms,
Okay.
and they'll all be coming back.
All right. Here they come. Shoot, everybody's back.
We're back.
That was
Awesome.
quick.
Yeah.
Sorry, Carolyn, you got cut off.
Intended to be rapid. Just, a little fun to get us warmed up. But we're going to do one more round. Let me get you ready for that. So in the second round, we're going to ask you to take 60 seconds each to tell each other what you do, meaning what your role is with the network. So for example, are you on a committee? Are you a program leader? Are you a program host? Do you provide funding to support some of the programs that we have going on? So you're going to do 60 seconds each to do that. And then you're going to take a third minute together to develop a hand signal that you can use to signal your new network friend. All right. So everybody ready? We've got one more person coming in here. So let's wait for Jerome to get here.
Right. I'll add one more room.
Okay. So that's the assignment. We'll drop that in your chat when you get to your breakout room. We'll see you again in a couple of minutes.
All right, and here we go. We're opening all the rooms. And we have Jen Collins in room 12. So someone's
I'm
need
gonna
to
jump into that right now.
Okay.
Thank you, Ariana.
And Cynthia Wells is not joined room 8 yet, Anne.
Okay.
So I don't know if you want to hop in with Mike Saylor.
Siler. Yeah. Go ahead and join that. Breakout rooms. Which room is he in?
He is in room 8.
Oh, it looks like, okay, and she has not gone.
Right. Hi, Sean. How are you? Oh, you're on mute right now.
I'm
just
good,
a heads
thank you.
up. We're doing a little breakout room icebreaker activity. So everybody is currently in a breakout room.
Thank you for the orientation.
Just a little something that Ann Morgan wanted to do with everyone, just to get them lively for this 8 a.m. Friday morning meeting.
Yeah, I thought it was 9, so
Oh,
I'm coming in late. My apologies, but thanks for telling me what's happening.
No problem. You probably felt relieved when you only saw a couple of us in here, but
Yeah, I did actually.
sorry to burst your bubble.
Then I thought, am I in the wrong session? But so
I'm closing the breakout rooms now, so they should be back within 10 seconds.
okay.
We're back.
Well, that was fun.
All right. Well, welcome back, everyone. So now what I'd like to have everyone do is, while we're waiting for everyone to actually come back, just make sure that your camera is on and put yourself into gallery view.
You got to stop sharing your screen for us to be able to see everybody.
Oh, I do?
Otherwise, we can only see a couple people on the side.
Stop share. How do I stop sharing? Shoot.
You did it.
Yeah, you're good.
It's perfect.
Okay. Is everybody back?
I think they have to be, right? They were kicked
Yeah.
out.
They got automatically pulled back in.
All right. And Dan, are we recording again?
Yes.
Yep, we're still recording.
Okay, awesome. All right, so everybody get your cameras on and put yourself in gallery view. And what we're gonna do next is everyone's gonna share their secret hand signal. All right, so on the count of 3, 1, Dan, get a screenshot of us. 2,
I'll see what I can do.
1, 2, 3. Awesome.
Very nice.
All right. I hope everyone had a little bit of fun with that. I think we had fun thinking about it.
Yes. Thank you for that, Anne.
And I'm sure there's a little story behind all of those little hand signals. So let's keep using them every time we get together. All right. So now that we've gotten through that, we're going to just hop into the agenda. And like I say, we do have a lot to share. It's been a while since this group has met. And a lot has happened since the last time that we got together. So we're going to start with the network update. And so Anne Holland. Oh, need to share my screen again. So bad. Thank you, everyone. So, so Anne Holland and I are going to go through, give everyone an update on the update that we had to do for our strategic plan. So I know, the last time this group gathered, we reported that the Integrated Network Development Committee and the Heart Network Board of Directors had accepted a strategic plan. When we received this new HRSA grant, we actually thought we had it in the bag, like, oh, good, a deliverable that's due right away that we're not going to have to do. We've already done the work. But they did ask us to go through a process to validate the strategic plan. And to do some additional, some additional work to kind of take a look at the quality, I guess, the strength of the relationships that we have as network members. So, so we went through that process. The INDC was great, and we also did an all partner survey to get feedback from all of you to get your impressions of how we're doing. So I'm going to turn it over to Anne Holland to talk with us a little bit about what we learned. And Anne, you just tell me when you want me to advance slides.
Yeah, I think you could advance to begin with. Good morning, everyone. Nice to see you all. It was fun to chat with a couple of you, a little more drilled down. So as Anne indicated, the update really, because it was only 9 months since we did the full blown strategic plan, we really only did 2 activities. One was a validation with the INDC, and the other was the all partner survey. So you could advance the slide, please. And the all partner survey, just to give you a little bit of context, the HRSA TA staff felt like we needed to conduct a perception study, which is a particular kind of set of questions about the relationships, both internally and externally, of the membership of the partnerships. So the content of the survey was very specific, using an adapted set of questions from a recommended survey. So it wasn't like we pulled this out of a hat. This was sort of very deliberate to meet the objectives of HRSA and to reveal some information to us. So Laura Morris, you know, this was a very specific and prescribed content survey. And the other piece I want to tell you all is, don't be surprised if you see the same survey again next year, because they wanted it to be a perennial survey that was conducted with the same partners or the same group of cohort. And so that we could compare, you know, year to year the results of it, so that we could see trends and see whether we're making progress. So we had about an 83% response rate, 29 responses. You know, SurveyMonkey tells you how long it took people to fill out the survey, which is really interesting because we said 10 minutes and people generally spent a lot less. And what we did notice is that a lot of people skipped questions and just moved on really quickly. And I don't know if that's because they were uncomfortable with the questions, but we did have a lot of people, not a lot of people, but 6 people generally out of 29 skipping questions and just moving on. And we had another 2 to 4 that just basically said they didn't know. So, you know, the quality of the response gets diluted by those situations where people skip questions and don't know. So you have fewer people commenting. So what we decided to do was to aggregate the questions. So we'll go to the next slide, into 4 sort of columns of material. And I hope you can read this because the background kind of comes into it. The first set of questions that were pertinent, rather than just simply who is Sean Sabella and who does he work for and what's his role and title, had to do with how the network is perceived generally from the outside in. And what we basically did is took those questions, took the weighted average, because the answers were on a scale of 1 to 5, and where we got the highest rating, you know, weighted average, we put them in order of how they rated. So anything above 4, correct me, and if I'm wrong, is good, and anything below 4 isn't as good. Or is it the opposite? I feel
no, that's right. Yeah, the closer to 5, the better, you know, the better the result. And
right. Boy, that was a 8 o'clock dyslexic moment.
Right.
Okay. So, and I color coded them this way so that, you know, we used 4 as the cutoff. And I know it's really hard to read these, but I think Anne was sending out the original slide deck so you could go through all the, you know, this material and see it because it is kind of small still, even on the screen. So generally we did pretty well on this question. How about the next one? Next slide. Okay, here were the partner commitment questions. And again, they skewed a lot higher on, you know, people understanding the goal, and understanding, you know, we're all rowing the boat in the same direction. I think that was a good sign, better understanding. And we were concerned about this set of questions because there had been some anecdotal information that people were confused about the organization, the network, and what the network's responsibilities were individually. All right, next one, and jump in anytime you want, Anne. The
Mhm.
third group of questions was about partner trust and communication. And again, we didn't get perfect scores in any of these, but we got pretty high scores in some of them, and in others we didn't. Here, that communication and trust was improving, and pretty good as a benchmark here. And then the last group of questions, could put the slide forward, was about decision making. And here we sort of did 50-50. Not terrible, but not, we could always do better. And here we were just discussing the ways in which decision making was made. Was there enough flexibility? Did people have opportunities to go back and consult with their employers? Were people willing to compromise? And again, there are things that we could do better, like, getting the folks involved in the INDC and in the partnership that really can represent the organization, and not have to always stop and go back or be unable to represent the interests of their organization. That's kind of an important one. And improving decision making, either where you're going to use shared decision making or whatever decision making models you're going to use going forward. And then the last question was sort of, do we put the last question first? It had to do with capacity. Excuse me, I forgot we have 5. And
There's actually, yeah, I'm sorry, Anne, but to interrupt, but yeah, there are 2 more. So you've got the capacity, and then the one question was the last slide. Yeah.
Right. I'm sorry.
Nope.
So capacity, we didn't do as well, because we don't have the adequate funds to do what we want to accomplish. Who does? I'm wondering, out of all the 29 people here, couldn't we all use more money? There's a lot of work. There's a lot of sunk costs associated with the work that you're doing. And everybody is facing the bandwidth issues of the post-COVID era. So, this is an area of issues and concerns that we need to be focused on. The last question, sorry, Anne, the last question could have been the first question, and we just chose to put it at the end. So from a strategic point of view, 4.46 out of 5 points might not get us a gold medal in the Olympics, but it certainly is a good sign that the investment you're all making in the network appears to be valuable to your organizations and to yourselves. So that's a good sign. I guess if we came with a 1 here, we would be questioning what we're doing, or even a 2 or a 3. But this was a high enough scale that there was confidence, not to generalize to all the partnership, but to the 29 respondents that came through and answered this question, that this was a good sign. Anne?
Yeah. And then I think, we thought that this was an interesting process. We had lots of feedback from, from individuals that were participating, and we even had one individual refuse to participate. But the feedback that we were getting from everyone that we talked to about this survey really was summarized very nicely by this one statement, which is that in some, that there's confusion. I think that there's a lot of confusion among the partners about all of the different networks that are in operation right now, the different programs that are out there, and a lack of understanding about how all of these things come together. So we've taken that information. Coming up here in a couple of minutes, there's a response to that, or the first attempt at trying to help to resolve some of that. But I think overall, we felt very validated. Nothing really changed in the strategic plan itself. The strategic directions remain the same. What this survey really helped us to do, though, was to start to understand how we might improve the marketing and communications direction that is part of our strategic plan to better communicate with all of you about, what the network is doing and what the various members are doing. So part of that, so feeding into that, then we already have a work plan, a marketing and communications plan that includes a lot of, attempts or, activities that are really intended to help us get to know each other and keep each other informed of what each other are doing related to the network. But as a result of the survey, we're adding some new activities. So what you see in black is what we're already doing. What you see in white are some new activities that we're adding, and you'll start to get a sense for. So providing education at our outreach meetings about a quality team concept. We're finding that a lot of your organizations, your larger organizations, have multiple people involved in one way or another, but you may not realize or understand what the right foot is, and the left foot are doing. There's no real coming together of the different stakeholders. So looking at how we can work with your larger organizations to bring those various players together to create a unified, chronic disease prevention front for the organization. We're working on creating social media accounts on LinkedIn and Instagram. And we've actually just launched the LinkedIn. If anyone paid attention or noticed the Get Healthy this North Country This Week edition that came out on Tuesday, we're promoting the LinkedIn page, and we're really wanting to get at least 50 followers. And if everyone in this group joins, we're halfway there. But a LinkedIn account that really is just dedicated to Get Healthy North Country, our network. We'll be doing some one-on-one outreach, not just myself, but other staff that are involved. We'll be doing one-on-ones with all of the network partner organizations. And we're working to we've already created, and I'm going to demo that for you, a graphic that is attempting to show, what we're doing and how it all comes together as one. So these are just some new things that we're going to be doing. And certainly if anyone here has any ideas about how we might continue to, improve upon how communication internally with the network members, definitely share that. We want to hear from you. We want to know what your thoughts and suggestions are. So any questions about that before we move on? I see. Thank you to Ariana, I believe, who just dropped the link to the LinkedIn page in the chat. It would be great if we could have 29 new followers when we get off this meeting. I'm going to go look. All right. So another outcome, so part of what the Integrated Network Development Committee is doing, a big part of what that group is doing. So this is the steering committee basically for the Get Healthy North Country Network. We've got multiple network level projects that we're working on right now. I just wanted to make everyone aware of those. The payer strategies team really is the Integrated Network Development Committee. And what we're doing around payer strategies is just understanding and developing our plans for outreaching to potential payers or groups that might be interested in investing in helping to pay for delivery of these important services. So we've got, a 4-year plan. This is really dictated by the HRSA work plan that we have. But this year we were aiming to get to 21,000. And although we didn't get to a really coordinated outreach to payers, we actually did have two payers really, kind of step up and offer funds. So we've got $10,000 that was awarded by the Community Benefits Committee at Alice Hyde Medical Center to help support Northern Franklin County resident participation in programs. And we've also been able to specifically carve out $19,000 in another contract that we have that will allow us to pay specifically for or reimburse delivery partners for delivering or providing service to Medicaid beneficiaries. So we actually exceeded that $21,000 mark this year. We're at $29,000 that we've got dedicated now, outside of HRSA, dedicated to helping to pay for delivery of these programs. So that's the payer strategies team, big focus of the INDC right now. Every meeting that we have is really focused on payer strategies. Related to payer strategies is a billing structure study. One of the reimbursement opportunities that we have, but we're not able to participate in, would be billing fee for service with healthcare, with health insurance companies. And so we're really not sure. We have some ideas about what that might look like, but we're looking for a consultant to come in and really get a good, grip or handle on what we're trying to do as a network, what the services are, how we're working together, so that we hopefully can have some recommendations and guidance around, how we should be structuring ourselves in order to capture that fee for service opportunity that's out there. Marketing and communications we've already talked about, but we do have multiple project plans related to marketing and communications, not just internal to the network, but also how are we engaging and recruiting participants, people out there in the community that could benefit from these programs. So lots of projects there. We've got a committee, the recruitment strategies team, that has been working on, communication outreach to the community wide. And then finally, last but not least, and this may come as some news to organizations, we are in the process of getting information out to everyone, but we are looking at we're looking at our different options for basically an alternative to Compass, which is the platform that we currently use, our delivery organizations currently uses to schedule programs and to track participant, engagement in those programs. So don't be alarmed, anyone. This is a process. We're just doing our due diligence. We have a great product in Compass. We're happy with that. But we're just working through a process to make sure that Compass is indeed the platform that we want to stick with for the long term. So those are some big projects that we're working on at the network level. So any questions about any of that? I've thrown a lot out there. There is a lot, but we're having fun. Any questions, any comments from members of the INDC or other groups that are involved with any of these projects?
I think you did a great job summarizing everything.
Thank you, Ray. With a Y. Okay. All right. So I want to go back to that comment, and the other feedback that we've been getting anecdotally from people who participants in this network who are confused about this network versus other networks that are out there. And so what I want to do is I've created a graphic. It's pretty complicated. I'm gonna not show you everything at once, and I do have a script that I'm going to follow, just because, like I say, it's a little complex. But I hope that this is going to help us to all understand what is it that we're doing again, who are we, and what are we doing, and how do we all fit together. That's the intention of this next graphic. So who are we as Get Healthy North Country? I'm just going to read here off this slide, but we are working toward becoming a community integrated health network that is, composed of medical and behavioral health care providers. We have public health. We have offices for the aging. We have social care agencies, and we have other local and regional chronic disease prevention program stakeholders. And what we're doing is all coming together to collaborate to offer coordinated, comprehensive, evidence-based products and services designed to reduce the burden of chronic disease in the North Country. Our mission is to reduce that burden across the region, and we envision a health and social care delivery system that emphasizes prevention, not treatment, of chronic disease, and one that offers every North Country resident equal opportunity to live their healthiest life. So the framework that we have been using, for those of you that have been with us, going back to 2019, the framework that we've been using to really organize all of our work and to identify potential gaps in our region is a framework that was developed by and is promoted by the Centers for Disease Control. And so this is where I'm going to go on script because I don't want to miss anything. So the CDC uses this nationally to help organize and connect our agencies locally in a way that allows us to identify gaps, build synergies, and reduce duplication of effort so that we as a network are effectively and efficiently reaching and supporting all of those who are at risk for or in need of additional support to better manage their chronic condition. The CDC recommends that in order to prevent chronic disease efficiently and effectively, we need to ensure that we are coordinating chronic disease prevention efforts in 4 key domains, starting with epidemiology and surveillance. Activities coordinated in this domain involve research and data collection to help guide and prioritize program and service planning efforts. They also include development of evaluation plans that will help us to monitor program and service impact on individual health outcomes and population health. This work is coordinated through our data team and supported by Adirondack Health Institute, who serves as our data hub. There are currently 2 chronic conditions being monitored by network participants: diabetes and heart disease. This network, the larger network at Healthy North Country, is specifically focused right now on diabetes as a way for us to really hone in on develop all of our processes and get and become efficient so that we can then expand and bring other conditions into the mix. Another participant in this network is called the Chronic Disease Care Coordination Network. And you'll see where they fit in here in just a moment. The focus of that network is heart disease. So I've added that here in the epidemiology and surveillance domain because we've really got 2 focuses going on among our membership. Next is the environmental approaches domain. Activities in this domain aim to make healthy behaviors easier and more convenient for people. Programs and initiatives led by Get Healthy North Country participants in this domain area include creating healthy schools and communities, advancing tobacco-free communities, and the Adirondack Food System Network. All of these initiatives employ strategies that aim to change the context in which we all live, work, and play, so that no matter who we are or where we all have equal opportunity to choose nutritious foods, to be physically active, and to live a smoke-free life. Chronic disease prevention efforts in the health systems intervention domain aim to increase provider office, not just providers, but the whole office, and processes to increase identification of patients who are at increased risk for or already diagnosed with a chronic condition. Get Healthy North Country participants are involved with several initiatives that aim to support healthcare provider efforts to increase support to these patients. Most of the healthcare organizations here are involved with the Chronic Disease Care Coordination Network. And you're going to be hearing a little bit more about what that network is working on in just a few minutes. We also have North Country Nicotine Consultants, which is also, from a statewide perspective, is called Health Systems for Tobacco-Free New York. And the Food for Medicine program also falls into this domain area. All of these initiatives offer technical assistance, resources, and other support to help provider offices promote and support patient efforts to reduce risk and better manage their health. Last but not least, we have the Community Clinic Linkages domain. Activities in this domain from a community perspective are aimed to ensure that people who with high risk or with chronic conditions have access to quality community resources that can help them to better manage their condition. Many people here today, many of you here at this meeting, are trained as to lead chronic disease self-management education programs, the National Diabetes Prevention Program, and or other evidence-based nutrition education programs. Our network also includes a growing number of tobacco treatment specialists who are trained to support individuals attempting to quit nicotine, either individually or in groups. And where we don't have a TTS or a tobacco treatment specialist available, all North Country residents have access to the New York State Smokers Quit Line. Through the Get Healthy North Country network, organizations that are providing all of these services have access to additional training and technical assistance opportunities through the St. Lawrence County Health Initiative for CDSME and NDPP, and the Heart Network for tobacco treatment specialists. The linkage between clinic and community continues to be a challenge for us. We don't have a single easy-to-use process that provider offices can use to refer patients to community programs at this time. It will be a focus of the Chronic Disease Care Coordination Network's work plan to explore this and other barriers to getting patients connected. We are all waiting, though, and hopeful that the Social Care Network will be established through the 1115 waiver will result in identification and implementation of a system that everyone can use to facilitate referrals. So my hope is that this presentation within the presentations today is helping everyone to better understand not only the framework that we're all, contributing to, that's helping this network to organize and guide our planning. I hope that it has also helped everyone to see how all of our programs, services, and networks are working together to create a robust North Country chronic disease prevention system. And so that's that. I don't usually go do well with scripts, but I felt like it was important that I get this right. So any questions about that? Reactions? Is this helpful?
I think we should give you a round of applause.
Thank you. Is this helpful? Does this clear things up? Does it help people who might have been confused to understand how we're all working together?
I think this is a good summary and of all the efforts that are going on in the network.
I agree as well. So it definitely clears some things up for sure. And I think it just kind of lays it out there. And you did an excellent job explaining it. So thank you.
Thank you. It is complicated. It is complicated. This isn't easy. And I'm not sure how we create, any single piece that can really stand alone without explanation, because it is complex, but we'll keep working on it. This is a starting point, and we'll continue to develop, and your feedback is very important is part of that process. So I encourage you to please, speak up, look at this. I'll be sending the slides out after the meeting. If you have any thoughts, please let me know. Okay. All right, we're going to move along then. Thank you.
I'm sorry, and I just have a question. So is the name officially changed to Get Healthy North Country Network?
It did. We changed that with the HRSA, with the award of that HRSA grant. That's what we called ourselves for HRSA, and it kind of ties in with the webpage. Yeah. So we are officially the Get Healthy North Country Network.
Okay, perfect. Thank you so much.
You're welcome. Anyone else? Okay. So with that, then let's talk about what's happening in the community domain. And I'm going to turn it over to Amy Kohansky, who is the project director for the Chronic Disease Care Coordination Network.
Hello, everybody. So I was at first thinking that we're ending at 9, but we have till 9:30, right?
Mm-hmm. Yeah.
Okay, that's good. So yes, I wanted to talk just a little bit about the Chronic Disease Care Coordination Network. It's a 4-year HRSA grant, and Katie Margison is the network director. She's here on this call. So Katie, please feel free to chime in anytime you'd like. We are in the first year, the third quarter of the first year of this grant. And so this is supposed to be a planning year. And so we're definitely doing a lot of that right now. So hopefully you'll be able to see by the end where you can fit in. If you'd like to contribute, if you'd like to be part of it, we'd love to have you. So next slide, please. I'll give you a brief overview of what the grant is. I know many of you here on this call are very familiar with this already, so I'll try to be brief. We have 7 official network members that were named on the grant, and we have fully executed MOUs with these 4, CVPH, Hudson Headwaters, Alice Hyde, Northwinds IPA, AHI, the ACO, and the Heart Network. And so next slide, please. We also have a lot of other partners. And so listed.
Hold on, sorry.
Yeah.
One little point of clarification on this one for anybody who doesn't know. This particular HRSA grant is held by AHI and not the Heart Network, but we're very intertwined in many ways. So I just wanted to clarify that for anybody who doesn't know.
Yeah, I was going to say that and I forgot. Thank you, Katie. Here's our list of some of the other partners who have been coming to our meetings. It may not be extensive, full, but these are some of the other people who have been engaged, and we're very happy to have them. And again, like I said, if you're not on this list or the previous slide, then you're welcome to join us. Next slide, please, and I'll tell you about who we are going to be, who our focus population is. We are a rural, we're focusing on the rural areas, and that as of what HRSA requires. So Clinton, Essex, Franklin, Hamilton counties are our focus area. Our patient focus area is heart disease, but we're also including the contributing factors of hypertension, diabetes, prediabetes, obesity, and tobacco use, because they all contribute to heart disease. Medicaid fee-for-service and Medicaid managed care, our participants are also the focus. Next slide, please. So our main goal, if I could put it into 2 words, it would be identify and refer. And Anne spoke a lot to this as far as what the entire network is working on. So we're working to develop more effective case management or care coordination strategies to help identify what the patient's needs are and then refer them into the appropriate evidence-based self-management programs. These programs are provided primarily by community-based organizations. So there is that clinic community linkage that Anne was referring to in that last presentation. That's where really our focus is we're working in the clinical domain in order to help identify patients in need and then refer them to the appropriate self-management programs. And this is a co-creative strategy. So we're definitely working with our partners to say, like, what is it that we're exactly going to be doing? The workflows and the system changes has to come from within the individual partners' organizations. So we're not here to tell you what to do, but we're only helping to facilitate the changes that you would like to make. And next slide. So we had to choose particular programs and services that we were going to be focusing on because there are so many. And so the chronic disease self-management programs is definitely high on the list. If you're on this call and you're not really well informed about what these CDSMPs are, I would love to talk with you more extensively about it. So please reach out to me. I'm happy to come into your clinics, come into your offices and talk to your staff about what they are. These are programs, the more you know about them, the easier it is to talk to potential participants about them. So it's like important to know things like they are a 6-week program that requires 2.5 hours per week to do. So that would immediately preclude some people from being able to take them. So those kind of details is really helpful to know about. The NDPP, of course, is a year-long program. So anyway, I would love to talk to you more about these and more extensively if you ever want to invite me into your meetings. Tobacco treatment cessation is another big one that very much relates to heart disease. So we're working with the North Country nicotine consultants to, help facilitate the work that they're doing. And then thirdly, nutrition education programs, which include, referrals to registered dietitians, to certified diabetic educators. If they are in the SNAP program, referring them to SNAP Ed nutrition education programs. Produce prescription and medically tailored meals. We don't really have a lot of those programs in the area right now, but maybe by year 3 and 4, we will have more, hopefully. So stay tuned for that. So I just wanted to say one more thing is that even if what other referrals that could play into this are referrals into behavioral health, referrals to substance use disorders, referrals into housing, all these different referrals, even though they're not the focus of our particular grant, the work that we're doing to better identify and make referrals into programs will flow into all these other aspects as well. So I just wanted to make that clear that even though we're doing our data collection and such on these particular referrals, all the referrals for all the needs are eventually going to be taken care of through these processes, hopefully. Okay, next slide, please. So in years 2 to 4, we hope to do some pilot programs, certainly within the 4 major clinical partners that we have, but not exclusively with them. We want to, identify processes and then put them into use. How are we going to be making these identifications and referrals? So another piece of this is we also want to make sure for sustainability that we are optimizing reimbursement for care coordination, chronic disease self-management. And there are a lot of opportunities to do this. So we want to make sure that and help facilitate the proper billing and coding for the work that is being done so that the clinical offices can get the reimbursement that they need and deserve. So if you're interested in doing a doing a pilot program with us, please, that's another opportunity that you could join forces with us. Please let me know. Next slide, please. So one of the first deliverables that Katie and I had to do was do an asset map and gap analysis. I have a link to the asset map below here. Lisa Cyphers from AHI was very instrumental in putting that all together after Katie and I, as well as other members and partners, collected the data. I don't have time to go into this a whole lot right now, but just if you haven't already seen the asset map, you check it out because you might find ways in which it is useful to you. And I've already used it several times myself when looking for clinical practices in a certain area for say, that's all in there, plus so much more. So please check that out. And I did want to talk about, we also did a pretty extensive gap analysis with some really intriguing findings. I'm not going to go into all of that here, except for I wanted to share one particular gap that we did find. And so on the next slide, I think I talk about that, which is that in our 4-county region, there's 33,000 people who smoke and only 12 tobacco treatment specialists. So that's a ratio of 2,750 to 1, which is kind of, shocking in a way. But it does kind of show that maybe tobacco treatment specialists are not getting the recognition that they need and how powerful that they can be to help people quit smoking. And I've seen it directly. I was trained as a tobacco treatment specialist, and I worked very closely with certain providers. And with that relationship between the provider and the TTS, they can really work together to help the person in need quit smoking. So it's very valuable. And so we are hoping to increase the number of tobacco treatment specialists in the area over the next 4 years, but we're also want to make sure that people are very familiar with how they can use the New York Quit Line, which offers a secure closed loop referral platform that is also trackable. So more to come on that. If your office isn't already using that, then that's another way that we can work with you to show you how you can begin to make those referrals and then track them yourself. So that's the gap that I wanted to explain to you. And then I think we're going to move on to the next slide. Oh, I think I'm done. I did have another slide in there that I think, what did it? I thought I had one more. Maybe it just said, oh yes, our meeting is, our meetings are the 4th Monday of the month. And so that is this coming Monday. If you have any interest in joining us, please let us know. We'll send you an invite. And yes, we're going to be talking about data collection. So if you're in one of the 4 primary care places in Alice Hyde, CVPH, Hudson Headwaters, or Northwinds IPA, we very much recommend that you have a person at our meeting on Monday to talk about data collection. So, okay, thank you very much. I'm done.
Thank you, Amy. Anybody have any questions before we move on?
That was my rapid fire. Hopefully it was fast enough.
Okay, thank you, Amy, and thank you, Anne. I have a very small update, but really quickly, I just want to ask Anne, do you have on your slides anywhere a picture view or a snapshot of what Get Healthy NoCo looks like right now?
I don't, but we can go look at it. Do you want me
Yeah,
to
well, it's
stop
okay.
sharing?
No, that's fine. I just would like to encourage everyone at some point in time to take a look at what gethealthynoco.org looks like right now.
I want to go.
Okay.
I'm gonna go do it.
Because it is very relevant to capacity right now. You are going to notice that we do have some farther away partners who aren't part of our immediate catchment area, including Oswego County Health Department. We've also welcomed Jefferson County and Lewis County partners to the network, primarily supporting, in their area, but with the idea that they may in the future also offer virtual opportunities to the participants in our region. So that's really exciting. And I encourage you to take a look, though, at all of the offerings right now that are on gethealthynoco.org. Our patients should be able to find something that fits for them. And if they don't, we do have a wait list opportunity, and there is a place on gethealthynoco.org where people can ask for more information and immediately be added to a callback list. So really great to see. I encourage you all to take some time to look through these and yeah, thank our partners for sure for offering so many opportunities this year. Thanks, Anne.
Great idea, Anne Marie. Thank you.
So for me, I'd just like to share from a training and technical assistance perspective, what we have as far as partners supporting. You can go on to the next slide. Partners supporting these programs, and then with that, the number of peer leaders that we have across the region. So for 2023, you can see here the number of workshops by delivery organization. Again, Claxton Hepburn Medical Center, your team, Shannon and Michelle, are regularly offering through their diabetes center. So kudos to them for providing this service to so many of our community members and accepting them from across the North Country region. Also, you'll see here everyone else who has been providing the opportunity to our community. So thank you to each of these partners for doing this. I pulled this information from Compass. I would like to just share that with that transition from the New York State Office for the Aging to us, I think that everything is very smooth in there, but there may be a missing piece or something that got dropped. So if you do see any discrepancies here, please just let me know. Next slide. And then the peer leader count for this year. This is as of yesterday that I pulled the data. We have 48 peer leaders across the region trained in CDSMP. About 11 of those are volunteer. And then for cross-training, we certainly have the majority of our peer leaders who are cross-trained in diabetes self-management program. Coming up second to chronic pain self-management program. So Julie and Jerome did just finish up 2 cross-trainings for DSMP and chronic pain self-management program. So those numbers might increase here in the next few days. We have some peer leaders, enough to do a class here and there of cancer thriving and surviving, and certainly several National Diabetes Prevention Program partners who can, there's coaches, lifestyle coaches who can deliver that program. Finally, something that we don't do as often of, but I'm happy that we do have capacity to do that, is workplace chronic disease self-management program. We have about 10, maybe 11 partners who do that. Next slide. I think that's just our contact information.
Mm-hmm.
Are there any questions for the Training and Technical Assistance Center?
I think this is great, and I just have to extend, a big thank you to Julie and Jerome for all of the work that you do to help our delivery organizations be well prepared to offer these programs, and a big thank you to the delivery organizations. Many of you are represented here for getting these programs out there. It's really important that we continue to stay focused on this. I think from a capacity perspective, we're definitely making improvements. We still are very heavy St. Lawrence County, and we want to continue to really push that growth in the Clinton, Franklin, Essex counties, and even south to Washington, Warren. So, but thank you to Julie and Jerome, because without your support, this wouldn't be happening. So I know that it takes a lot of work and a lot of effort on your parts to bring these programs to fruition. And anyone else have any questions? Okie dokie. Okay, so so the final piece of our formal agenda is just to help you understand what we're doing to make sure that we're measuring success. So again, go back to that framework, epidemiology and surveillance. That's actually where it all starts. We started with our priority focus area on diabetes and heart disease because of what the data and surveillance was telling us. But it loops back around because now we need that same data and surveillance to be able to demonstrate that what we're doing is actually making a difference. So I'm going to turn it over to Laura and Kate, starting with Laura to kind of go through our evaluation framework.
Great, thanks. So when we, started on this adventure, we, as a group, sat down, looked at what we were trying to do, what our goals of the project were, and what sort of information, we wanted to be able to report out of that. And so as part of that, we came up with these evaluation domains. So you can see we have process measures related to program delivery referral. We have various outcome measures, as well as sort of cross-cutting measures you see at the bottom. And so over the last year, as we've been collecting more data, as more participants are going through the programs, Kate has put together a couple of dashboards that are available if you have a user account, and if you're, as you see, Kate's going to demo it in just a minute. If what you see is something that you want to go look at regularly, we update it as, we're getting data from the program. Reach out to me or Kate, and we can get you a user account into there. So far you'll see we've developed, Kate has developed views related to the process measures. So we're going to see that, as well as, what we're calling patient reported outcomes. So there's a survey that's completed by the participants at the beginning of the program, before they've gone through the program, one at the end of the program, and then there's one at 3 months, and we don't have the 3 months post-program results yet, but we do have some of that, kind of initial and kind of end of program survey results. We are abstracting data for clinical. For people who grant us HCSCN and Healthy Connections consent, and we're gonna start working on converting that bringing that into a dashboard over the next few weeks, a couple of months. We also have population health data that's coming from HCSCN. HCSCN itself has a population health dashboard. And so that we've also pulled that into the dashboard, as Anne said, that in some ways that was our starting point really of, determining where some of our focus was going to be. And we will be we are also collecting patient characteristics from the enrollment and intake surveys. So that will also be something that we're adding on. Cost of care, we still need to do some thoughts around that. That will be a little bit longer coming. So all of this is just to kind of lay out. So as Kate kind of walks us through what's available right now and, what we're seeing year to year, you kind of understand how it fits into our evaluation framework that we've built.
Sure.
With that, I'll yeah.
Sorry.
Hand it over to Kate.
Would you like me to share my screen or?
Yeah,
yes.
I don't have it up. Yeah.
All right. Here we go. Can you see that?
Mm-hmm.
Can you just minimize like the filters and visualization and fields?
Yes.
Just so that we can.
just a second. You gotta make it a little bigger.
Yeah, exactly.
All right. So this, you know what? You could see all that stuff because I was actually on my desktop, not on the actual dashboard. So this is what the DataDin dashboard looks like. You will log in, you know, supply your password, and depending on who you are, you can see like varying reports. But the two that we're looking at today, one is called the chronic disease burden, and I think that's program metrics, it's cut off. And the other is the pre-post data visualizations. That has to do with the self-reported patient outcomes. So we're just gonna click on the disease burden and program usage. There we go. Now, I'm going to be going through this rather quickly because we don't have a lot of time left in the schedule. However, if you do decide to, you know, look at it later and you have questions about anything or any comments, you know, definitely we are always available. So don't hesitate to reach out. So the disease burden primarily comes from HCSCN. And I do want to sort of emphasize that this is not only limited to folks who have gone through our programs. It's filtered by geography. So just something to keep in mind. So we have in the top section the different chronic conditions we are trying to influence, both the prevalence and the count. So I'm just going to click on hypertension. Hypertension is not like a great metric in my opinion. You know, you can see that like more and more people seem to be experiencing this problem. Some counties have, you know, having a much higher disease burden than others. But in all of the prevalence charts, you pretty much see the same thing. The blue dotted line is just all of the counties that we're focusing on together. And then the solid line would be this particular county. So like this particular graph is for Clinton County, and you can see that Clinton County, you know, is not doing super well in terms of hypertension prevalence, even compared to like our, what is it, 5-county region? Wait, 1, 2, 3, 4, 5, 7, sorry. Although I will bring up diabetes control is one of the bright, like rare bright stories. For some reason in this area, we are doing better through the years at diabetes control. Those are all expressed in like percentages of population. If you want to look at actual counts, you know, you are welcome to do so in the next section. Just sort of be aware of the fact that these are just raw counts, so you have to kind of take into consideration like the population of the county and things like that. A low count in a low population county doesn't necessarily mean you're doing great on diabetes or whatever metric you're looking at. And then down here, this is the program utilization. This data comes from our network, primarily from Anne. So you can just see, you know, how many workshops did we start versus our target, and it's broken down by type. What was the enrollment? This is like actual number of people enrolled. And then not everybody completes. So sometimes you have people who enroll, but they don't complete. So, you know, how many people actually manage to complete? And then this is just a quick visual that sort of gives you an idea of what percentage of these folks were referred by their provider versus like getting to the program some other method. And as Laura had mentioned, we do also collect these surveys on folks. And they're actually in the surveys asked a variety of questions. These are just like a few that we've pulled out and highlighted that seem the most salient, I guess. But there is more information about these patients that we know. Not everybody apparently who goes to the class turns in their data or completes a survey. So there might be a little bit of mismatch between, in the last report, you saw that like X number of people completed the program, but we don't actually have that many people like in this dashboard. It's believed that is because we can't get everybody to actually like fill out the surveys, even if they took the class. But they're asked things like, do you feel like you're in control of your health? How confident are you to manage your condition? Are you making lifestyle changes? And you can just kind of see like who, like pre and post, you know, what were the, what did the distribution sort of break down? We also look at it in from a like a did people improve perspective, because when you're looking at those graphs before, like they say like, oh, so many people said they're they exercise 5 times a week now, but that doesn't really tell you like, well, were they doing it before, like is that an improvement? So here you can see these same questions just sort of broken down into like, did people actually improve before and after the intervention, which is like the workshop. So I'm just gonna like highlight one of the more positive ones. So here, like, do you feel that you currently make healthy lifestyle changes? Like that's people saying that they exercise or they eat more vegetables or whatever it is that they need to do to manage their condition. And like the majority of people, like 57% actually said that like they increased their score. They're more likely to make these healthy lifestyle changes. And then like around 18% just stayed the same. Only about 25% said that they're not they're less likely to make these changes. So overall, like, the net, it's fairly positive. So that's just one additional way of looking at it. And I'm not really going to go into depth about any of the data because this isn't really the right meeting for it, but just to reiterate, you're welcome to reach out to get access to the dashboard or to ask any sort of questions you might about the actual data. And I think that's it for me.
Thank you, Kate. I wonder if I could have you go back to the disease burden in program. I just want to thank you for that quick, like walkthrough. And as Kate said, anyone that's participating in this network is welcome to get a username and password to be able to access this information. So it is a work in progress. We are going to be adding, additional data, as Laura mentioned, to hit more of our data domains. But a couple of things that I just want to call out from a network, success perspective. If we click into the program utilization and look at the program started, we, for the last 2 years, have been setting our target at 26 programs to start. Doesn't mean that the program is completed, meaning, canceled because due to lack of enrollment or for other reasons, but just started. We want to have at least 26 start per year. And for the last 2 years, we've gone, above and beyond that target. And I would add that not only did we exceed that a little bit more this year than we did in 2023 than we did in 2022, But the program size, the average number of participants per workshop increased in 2023. And if you go to the enrollment numbers, you'll see why that is. So I think what this says is that, we've become much more efficient and, getting people into workshops. And, when a program is scheduled, we're more getting better at getting those workshops filled. And you can see a big jump in enrollment from 2022 to 2023. We're the target for 2022 and 2023, both years, was 262. We fell just a little bit short of that in 2023. We're going to be upping that to 300, I believe, starting in the calendar. It's not a calendar year that we go by for HRSA, but we'll be upping that for a 12-month period up to 300 next grant year. So, but I think we're well on our way. And I just want to, again, this is a testament to Julie and Jerome's hard work and helping the delivery organizations to get their programs scheduled and to, really hustle to help get people connected to those programs. So I think this is a real success. So, anyone want anything else here that people might want to ask about or comment on? There's one more thing I want to go to before we go on to the other. Julie, Jerome, Anne Marie, anyone else that's involved here have any comments about that?
I'm just wondering if Kate would be willing to put her email in the chat in case anyone wants to reach out.
Absolutely.
Access. Thank you.
On referrals, we've changed our tracking methodology. It's been very complicated for us to really get a good handle on how many referrals are actually happening. We developed a referral process where we were trying to, encourage provider offices to refer their patients through New York Connects to get enrolled, to provide support to get people enrolled in programs. That has been very slow. I think we have a couple of provider offices that are kind of on a somewhat regular basis sending referrals, but it's really not happening. So anyway, some providers are referring directly into the programs that they're delivering. That's certainly the case for Claxton Hepburn. We've got other providers that are referring directly to a Claxton Hepburn program. But because there were so many different ways that providers were making referrals, we decided that the easiest way for us to get a reliable kind of gauge on what's happening was to take that information from the people that are getting enrolled in the programs. So any person that registers through the program is asked, how did you get to this program? How did you, find out about this? And I can't quite tell what the numbers are, but you can see that there was an increase from 2022 to 2023. Registrants, it looks like just under 40% of people registering said that they got there because their provider referred them. That might have been a passive referral, meaning they just got the Get Healthy NoCo rack card. It might have been an active referral. We don't really know. But about 40% in 2022, and in 2023, that jumped up to 51%. And I do think a lot of that can be attributed to the big push of rack cards and posters that we continue to have a very large supply of. So if there's anyone here that wants to help get the word out, please let us know, and we'll get you a supply of rack cards and posters. But I just wanted to explain that, that we have changed our methodology for right now. We've changed our methodology and how we're tracking provider referrals. Any questions about that? Okay, and I think that's all I'm going to say. I'm going to open up the floor. Then we're back to questions, comments, wrap up discussion. The floor is anyone's at this point. Thank you, Laura and Kate. That was great. I'm really excited about the work that you're doing. No questions or comments?
I just appreciate everything you guys are doing. So it's a great initiative and I'm very happy to be a part of it. So sharing out as much information as we can. We put your rack cards on our informational tables wherever we go. And we regularly share your information in our publications. So thank you for all your efforts.
Thank you, Stephanie.
Of course.
I'm going to drop some important people's emails in the chat in case you do have questions. You can just grab the link there.
Awesome. Thank you. Anyone else? I'm going to LinkedIn to see how many new followers we have.
I'll just add, it was great to see the data. Thank you for sharing that.
How does Sean, now that you've mentioned that, how does that, I know that you've been talking a lot about that. We need more data. We need more data. How does that, is that helpful for you?
Very much so. I think it helps to kind of bring focus to it, especially, to highlight it, especially if our data, and there was, certainly the hypertension that was pointed out, Clinton County is not doing well. So that's a good thing for me in order to help, draw attention to it as an important issue that we need to do better with.
Mm-hmm.
So whether we're doing, well or poorly, in either case, it's helpful to know. Good to see that and be able to access the data. I just emailed Kate and asked her how I can get on board and get access to that.
Good. And Sean, the information that Kate shared that shows us what the pre and post participation results are looking like. Is that information that's helpful for you? Is like from your decision maker perspective, am I going to invest in this program or not? Is that the kind of information that you want to have presented?
I do think that's helpful right now. Just the more data, the better. And I think you're never really sure what's going to help make the point, but looking for ways to, get people, enthusiastic about, or, show, hey, this is a problem. What are we doing around this? So any way we can make that point. And sometimes, if we feel like we're making the right effort and seeing good things, that's helpful too. But I think, right now drawing attention to it is, I think, the primary, thing on my mind.
Excellent. Thank you, Sean. Put you on the spot. I know you're not shy. Anyone else? We've still got 5 minutes. You're welcome to leave. And I wanted, release you if you're ready to go. That's great. Thank you very much for your time. I know this was a very dense, information-packed meeting. I will be sending out the slide deck, and we will be posting a recording of this meeting at Get Healthy NoCo. We'll send that link out as soon as that's available. So I think we can probably stop recording, Dan. And then just like I say, I'm going to stick around for anyone that wants to keep having discussions.